Hi, I'm Akash, or Dr. Akash Doshi. I'm a endocrinologist and diabetes specialist, hence why I'm giving this talk. Perfect. So the things that we're going to be talking about, an introduction to all about this topic, talking generally about all the medications that are available in diabetes, and then some cases just to go through all of what we just talked about in the previous section and consolidate that information. Once again, this is me. So I'm a medical registrar, but also a specialist in endocrinology and diabetes. I run the website above, which is mindthebleep.com, where if you just go on it now, there's an article all about the medications and diabetes. And also you can catch me on Twitter at mindthebleep. So feel free to tweet me and ask me any questions or anything else that you'd like. So I think the first thing we need to consider when we talk about diabetes are what are the differences between type 1 and type 2 diabetes. So type 1, so diabetes is when you don't have enough insulin, and because you don't have enough insulin, your blood sugars go up. Insulin is the hormone which enters our bloodstream and basically allows our blood cells to take up the sugar and use it. In type 1 diabetes, the problem is that we don't produce enough insulin. And in type 2 diabetes, the problem is that we produce loads, but we're resistant to it. And so for that reason, it doesn't work and our blood sugars climb. So in type 1 diabetes, the symptoms you get are of not having enough insulin. Insulin, as I said, helps the sugar get into cells and helps your body grow. So when you don't have enough insulin, what happens is your body shrinks. You lose weight, you lose fluid, you get all of these very much osmotic symptoms, we call them, when you get lots of polyuria, polydipsia, and weight loss. With type 2 diabetes, it's much more of a longer history. And so we'll go through some cases to describe that. But essentially, weight gain or being overweight tends to be a key feature. The other thing is in type 2 diabetes, you have a significant family history. Lots of people in your family are diabetic, lots of patients on tablet-controlled diabetes, and so that really helps you work out what the type is. Why does that matter? Well, it matters because, again, type 1 diabetes, you don't have enough insulin, so the treatment is to give insulin. In type 2 diabetes, there's a whole host of different medications you can give, and the trick is to choose between them. The idea is to choose medications to both consider the microvascular risks and the macrovascular risks. So when we talk about microvascular risk, we're talking about the little blood vessels which supply different parts of our body. Here we can see a scan of the retina. So retinopathy or problems with your vision are one of those features. You can also get neuropathy, so you get sensory loss in your fingers and your toes. And the final thing you get is nephropathy or problems with your kidneys. In terms of macrovascular complications, the things we're looking out for are myocardial infarctions, hence the guy with having the chest pain, and a stroke. We're also looking for peripheral vascular disease. So our treatments what they need to do is improve not only your glycemic control, your blood sugars, which in turn will improve your microvascular complications, but it also needs to help with the macrovascular complication risk. And historically, a lot of the old medications actually improved the microvascular, they improved the blood sugars. What they didn't do is reduce the risk of heart attacks. And so what we'll do is we'll go through the medications and see how you can balance them. I think the first medication that everybody knows and they love is Metformin. I think Metformin is the drug you really need to know, because every single patient with type 2 diabetes should be on it, unless there's a good reason that they can't be. So Metformin works by targeting exactly the issue in type 2 diabetes, which is the sensitivity to insulin. It also reduces the release of glucose from the liver. By doing so, it improves a whole host of things. Not only does it improve the blood sugar, but it improves the blood pressure, the cholesterol, and it reduces the macrovascular complications. People have less heart attacks. People have less strokes. The risk, though, are the GI side effects. So when you start Metformin, people often complain of things like diarrhea, bloating, just generally feeling a bit nauseous, but they tend to go. They tend to only last a few days. So if you start somebody on metformin, you need to tell them these are some of the side effects that a small proportion of people will feel. And even when they do feel them, they tend to settle in a 1 or 2 weeks. The last thing to note is it can cause lactic acidosis. So this is in the context of acute illness. Metformin, like many of the drugs in diabetes, we hold in acute illness, because dehydration or anything that will stress out your kidneys will put you at risk of having lactic acidosis, which is when your lactate goes up, you can feel very unwell, and you can actually die from it. And so that's a big risk. Hence, metformin needs to be stopped, needs to be held when you're acutely unwell. And so we'll tell our patients to do so. How do we start it? Well, we'll start it as a first-line therapy for any patient with type 2 diabetes. Classically, the NICE guidelines say if the HbA1c is above 53. So HbA1c is what we're looking at is glycated hemoglobin, essentially how much sugar is there on the hemoglobin molecule. And this tends to reflect about 8 weeks of what your average blood sugars would be. And so if your HbA1c is raised, so there have been your blood sugars for weeks on end. If your HbA1c is above 53 after 6 to 8 weeks of lifestyle changes, that's when we would say we would need to start metformin. But actually in day-to-day practice, because of the really awesome benefits of metformin in terms of blood pressure, cholesterol, macrovascular complications, as well as microvascular complications, we would want to start metformin immediately. So any patient who becomes diabetic, in real life, we tend to start it immediately rather than wait. Again, if they've got poor renal function, their eGFR is below 30, we will not give metformin. The risk, once again, is lactic acidosis, and so that's when we would avoid it. We'd also tend to avoid it in liver or heart failure. So liver failure, so cirrhosis would be a contraindication of metformin. Heart failure, your risk is, again, poor perfusion to tissues. And so again, lactate can build up because you go through that anaerobic respiration. But in the context of heart failure, most patients, if they've got preserved renal function, they've generally got stable heart failure, we can start it. It's only those really advanced, really bad heart failure that we would consider not giving it. The take-home message, though, is it's awesome. Your patient should be on it. There should be a good reason why your patient isn't. Sulfonylureas. So sulfonylureas are, again, another very old drug. And for a long time, they were the second line and the only second line drug. The one that most people will be familiar with is gliclazide, because that's the one that we use most commonly. What sulfonylureas do is they attach to the pancreatic cell, pancreatic beta cell, and they make the body produce insulin. Not produce, secrete, I should say. Secrete insulin regardless of what your blood sugar is. That means if your blood sugar is high or if it's low, it will make your pancreas release insulin. Because of that excess insulin, just whereas we talked about type 1 diabetes where you have less insulin, you get weight loss, because in this you have too much insulin, although necessary, but because all the time it's high, this causes weight gain. Also, because it's making you secrete insulin, regardless of your blood sugar, you get hypoglycemia. If a patient comes into primary or secondary care and they're describing hypoglycemia, you can bet on it that it's either going to be a sulfonylurea or insulin. And it's about 50-50 in terms of at least where I see them in secondary care. So this is really the thing to watch out for. Patients who are at risk of having issues because of hypoglycemia really should not be on this drug. So that's the elderly, because there'll be an increased risk of falls. Those with kidney disease, because essentially they won't filter out the insulin, which means they're at even higher risk of having hypoglycemia. And in the same context, acute illness, because essentially if you're so unwell, you're not eating or drinking, you get dehydrated, you're not eating enough, you're at much higher risk of hypoglycemia. So another drug that we would stop in acute illness. The benefits are that it will improve your glycemic control. In fact, all of these drugs will improve your glycemic control, improving microvascular complications. What it won't do is really improve macrovascular complications. You won't get that benefit in improving heart disease, strokes, etc. And so these days, we don't tend to use sulfonylureas as commonly as we once used them. But like all of the other agents, they're a second-line agent. And so if the HbA1c remains above 53 after 6 months or so with metformin, we would start a sulfonylurea. And we would start it, typically glycoside, 40 milligrams once or twice daily, depending on how high the blood sugars were, and also when they were. For example, if the blood sugars were high in the morning, we would say that the overnight blood sugars were too high and therefore we need to start it in the evening, and vice versa. The next class, talk about the DPP-4 inhibitors. Now we're talking about medications that we use more commonly and actually are more beneficial. So how do DPP-4 inhibitors work? Well, you've got a molecule called GLP, which is secreted by the gut. And what it does is it tells the rest of our body that we're full up. And it also tells the rest of the body to produce insulin in relation to, I've just eaten, make some insulin. And so that's how DPP-4 inhibitors work. DPP-4 is the enzyme that breaks down GLP. And so by inhibiting that, we increase the amount of GLP, glucagon-like peptide. That means with meals, we'll have increased insulin. And we'll have, and because of that, you don't tend to get hypos, no hypoglycemia, because the insulin is appropriate to a meal. With DPP-4 inhibitors, they're weight neutral, and they help delay the need to start insulin. Linagliptin is one that we really favor in CKD because it needs no dose adjustment. Once again, we will start it as a second-line agent if the HbA1c is above 53 millimoles, but we're not going to give it alongside a GLP-1 analog. And I'll talk more about that on the next slide. So DPP-4 inhibitors, great for improving blood sugar, and unlike sulfonylureas, don't cause weight gain. So that's a very good advantage. GLP-1 analogs go that extra step. So whilst your DPP-4 inhibitors, they just augment your GLP, just to increase it slightly. A GLP-1 analog is basically giving you that GLP. And so these are supra physiological levels, they're pharmacological levels. And so everything that DPP-4 inhibitors do, GLP-1 analogs do that much more strongly. And because of that, you get that much more side effects. There's no point giving a GLP-1 analog and a DPP-4 inhibitor, because essentially if you're giving a GLP-1 analog, you're giving such high doses, the DPP-4 inhibitor is not going to really do anything. All it's going to do is stop the breakdown of GLP and increase your risk of side effects. So we don't give the two together. GLP-1 analogs will make you basically feel like this very content cat. They will work in the same way by increasing insulin secretion, but also increase satiety. You will fill up, feel happy that you don't need to eat any more food. Because of that, they cause significant weight loss, several kilograms in fact. But they're a bit more expensive. They cause a bit more side effects, and also for the time being, you need to give them via subcutaneous injection. And so there are advantages, but there are also a couple of disadvantages, which limits its use. The GI side effects can be quite potent. They can get diarrhea, feel quite nauseous, vomit, but these tend to settle, and so we'll introduce a small dose and slowly titrate up, just like we do with metformin. There's also a very small risk of pancreatitis. Once again, we tend to hold these medications in acute illness because having nausea, vomiting, diarrhea, whilst you're also unwell, can really put you at risk of dehydration, and so we don't want to do that. We'll start it once again if your HbA1c is above 53 millimoles, and we'll slowly up titrate it based on the patient's GI side effects. So GLP-1 analogs, very good for weight loss, very good for satiety, but slightly more expensive and slightly more uncomfortable to give because they're subcutaneous injections. So you've got to train the person. And then finally, we've got SGLT2 inhibitors. Well, sorry, next to finally, penultimate drug. SGLT2 inhibitors are outstanding. The evidence base is just growing, growing, growing. They work by blocking the reabsorption of glucose. So essentially, your kidneys don't reabsorb the glucose, therefore they pee out the sugar, and with that goes out the urine. And so basically these make you pee. This is your flozins, your dapagliflozin, your empagliflozin. All the trials that have been done in the last few years show excellent outcomes, excellent cardiovascular outcomes, heart failure outcomes, CKD outcomes. In fact, such good outcomes that cardiologists start this drug without even diabetes. It's been shown that you reduce the risk of a heart attack and reduce the risk of heart failure even without diabetes. So these are great drugs. They cause weight loss, not surprisingly, because you're peeing out the sugar. That means you can't deposit it as fat because essentially you're losing it. But because you are passing a lot of sugar through your urine, you're at higher risk of urinary tract infections, and you're also at risk of euglycemic DKA. That's because you're losing the blood sugar, so your blood sugar doesn't rise, but you get significant dehydration. And so that is a pretty bad thing to happen. If you do get ketosis, then SGLT2 inhibitors are contraindicated. No patients who have them, who've had ketosis, should have them at the moment. That may change, but because of the just outstanding benefits of them. But for the time being, if you've had ketosis, you should not get an SGLT2 inhibitor. The last thing to know is that, again, they must be stopped in acute illness. So the only drug you're not going to stop in acute illness thus far is your DPP-4 inhibitor or your gliptins, like linagliptin. All the others need to be stopped, in this case, because of that dehydration once again. You can start this if the HbA1c is above 53 and can be started as a first-line or second-line agent. And then finally, we've got insulin. Insulin is much later down the ladder. We're going to give metformin, we're going to give another agent, we're going to give a third agent, and after we've given max doses of those three agents and it's still not worked, that's when we start insulin. If the HbA1c is above 58. And that's because of the risks of insulin, and also because the amount of effort it takes for a patient to get insulin correct. It requires plenty of education, injection technique, self-monitoring, titration of the insulin dosing, management of hypoglycemia, and they've also got to inform the ZVLA and may lose their license, depending on if they don't manage to, essentially if they have hypoglycemia whilst driving. How do we start it? Well, we usually start about 10 to 20 units, approximately 0.3 units per kilo. And we will consider different regimes. So there's basal only, where you just give the one long-acting insulin that lasts throughout the day. There's the pre-mixed BD or twice daily regime, where you have a bit of short and long-acting component, and you give them together. So that's very good for if the long-acting will do exactly what the basal is doing, but the short-acting component will just kind of help with each meal. So you'll give that twice, so it will help with kind of breakfast and kind of tail off with lunch. And the second dose will help with dinner. Or the all-out version, which is the basal bolus. You give the basal, and then with each meal you give a bolus, which represents more similar to kind of our physiological insulin changes. Essentially, with each meal, we produce insulin all the time, and with each meal we produce lots more to accommodate with the excess sugar that we're eating. Sick day rules, you must not stop insulin. You must not stop your basal insulin when you are unwell. This is because people in illness, people who are ill, often require more insulin. And so by stopping it, you may result in the patient becoming very hyperglycemic and becoming very dehydrated as a result. Patients at home are usually asked, if they're on insulin, to measure their blood sugars every 2 to 4 hours. If they're in hospital and they're not eating or drinking, we'll usually switch them to a variable rate insulin infusion, also known as a sliding scale, which changes the amount of insulin that's going through a drip depending on your blood sugars. Finally, we can just briefly go over some of the other drugs. These drugs we don't use. So I don't think I've seen a patient on these drugs in a very long time. So there's the meglitinides, which work like sulfonylureas, but essentially they worsen cardiovascular outcomes. There's the glitazones, or the TZDs, which work by improving sensitivity to insulin, but they increase your risk of heart failure, cause weight gain, osteoporosis leading to fractures. And then there's the alpha glucosidase inhibitors like acarbose, which work by inducing malabsorption of carbohydrates, but they're not very well tolerated because of GI side effects. These drugs I just mentioned in passing, but aren't really drugs you need to really be aware of because they aren't drugs we use these days. They've been superseded, and also these are the older drugs that tend to cause more bad cardiovascular outcomes. That's a lot of information. And so what we're going to do is we're going to go over it again, but with a patient, allowing the case to contextualize some of that information, but also help you consolidate that information so you're able to retain it. So let's do that. Let's start with Mr. Andrews. Mr. Andrews is a 22-year-old male, and he presents with weight loss of 10 kilos, a short history of osmotic symptoms, polyuria and polydipsia, no known family history of diabetes. So this history is that of type 1 diabetes. He has weight loss, he's got a short history of osmotic symptoms, and describing quite significant amount of passing lots of urine, polyuria and polydipsia, really feeling thirsty. There's no family history of diabetes. So often with this autoimmune diabetes, type 1 diabetes, where you have failure to produce insulin because your body destroys the pancreatic beta cells, you don't tend to have a family history. You may have a little bit of a family history of autoimmune disease. Mr. Andrews presents in DKA. That's because he's got the diabetic component, that raised blood sugar, the ketone component, that raised ketone, and the acidotic component, the low pH of 7.2 and a bicarb of 18. All of this tells us that he has insulin deficiency because he has gone into a very catabolic state. Insulin, as we know, is a kind of a growth hormone. It helps build muscle, build fat. And given he's losing so much weight, it suggests that he's not got enough of it. And so he needs to be started on insulin. We will start with low doses and we will titrate that up because we don't want to start with big doses which crash the blood sugar of the patient and end up the patient having a hypo, because if you do that, they will never forgive you and they will always run their blood sugars high. Having a hypo is really awful, and I'm sure lots of you have been called out or seen patients with hypoglycemia. And so we would start something like a Basaglar, which is exactly Lantus, but the cheap version. And we'd start some Nova Rapid, which is the quick-acting insulin, and we'd split it. So 21 units, given he's 70 kilos. So what we'll do is we'll give 10 and 12 units, which is roughly 21 units. 10 units as fast-acting, and 4 units 3 times a day with meals as our short-acting. And we'll slowly increase that as need be, starting with the Basaglar to get that morning blood sugar, that fasting blood sugar all right, and then we will next work on our mealtime insulin. But essentially, this is how we would manage somebody who comes in to our specialist endocrine and diabetes ward. Or what you might do in the community if he was much better and wasn't in DKA and didn't need to come to hospital. Next is Mr. Patel. So Mr. Patel is a 64-year-old male, and he presents with weight gain and a few months of osmotic symptoms, which are much milder. He's got a strong family history of diabetes. His blood sugars are high, but his ketones are negative, and he's got a raised HbA1c. In your type 1 diabetics, they may not have a raised HbA1c because it's come on so quickly that their HbA1c hasn't had an opportunity to rise. Yes, there are some patients who do develop type 1 diabetes in a kind of slow burning process, but those patients will ultimately get to the point where they have DKA and demonstrate the need of insulin. But what we're going to do is we're going to keep things simple and just look at the kind of polar opposite patients. So the things that are making me think type 2 diabetes is ethnicity. He like me, is Indian, and therefore he's at much higher risk of type 2 diabetes. He's got a strong family history of diabetes, and he's having a bit of weight gain from that excess amount of insulin that his body is resistant to, and he's got a few months of slow onset of osmotic symptoms. His blood sugar is raised and his HbA1c is raised, but importantly, his ketones are negative. Therefore, he has enough of insulin to keep his body from breaking down all of the fat. It's just keeping the fat at bay. But what it isn't doing is it's not enough to bring the blood sugar down. So he's going to need a little bit of support with that. As we discussed, metformin is our first line because of those awesome outcomes in cardiovascular risk, strokes, and everything else. And so we will start metformin, warning him, Mr. Patel, you may have some GI side effects. You may feel a bit nauseous, may get a little bit of bloating and vomiting, but that will settle after a few days. In a week's time, we'll aim to increase your dose up. We'll increase it by 500 milligrams in addition every week until we get to the 1 gram twice daily dose, because that's what you need. If the GI side effects that you're getting still continue, at that point, we might, instead of giving you metformin normal, we'll give you metformin modified release. Metformin modified release is a lot more expensive, but that's what we're going to do because we know that it will prevent those complications which, from a monetary point of view, are much more expensive to manage, but also from a patient perspective, who really don't want to have Mr. Patel risk having all of those complications. We'll then remeasure his HbA1c 6 months later to see how things have changed. The other thing that we're going to do is we're going to address all of the other things, and this is something that I address in every single diabetic patient I see in clinic, in hospital, wherever I see them. We're going to ask them about diet and exercise. What are they eating? Do they know what they should be eating? Would it be helpful to see a dietitian or get some leaflets from diabetes.org, which has lots of information on what to eat? How often are they exercising? Do they want some help with that? Bariatric surgery, if they're overweight, so in the UK, if they've got a BMI above 30 and they've got diabetes diagnosed in the last 5 years, they're eligible to bariatric surgery, which is most diabetics, type 2 diabetics. And so that might be something that we consider. The next thing we need to think about is compliance or concordance. The way I like to ask is, most people forget to take their medication from time to time. How often do you forget? Because if I ask them, do you ever forget to take your medication, or do you always take your medication? They usually say yes, because they're worried that I'm going to either judge them, or they're like, well, I gave you that medication, why didn't you take it? I'm going to get angry at them. So if I kind of almost normalize it with this kind of a question, they tend to be more honest. And then I always follow that up with, in your case, you really can't afford to not to miss the medication, because in your case, you're at such high risk of developing all of these complications. But also, if you do manage your diabetes well, these are the advantages you'll get. It's always about a little bit of the stick and a little bit of the carrot. Next, holistic management. Most of my patients who have poorly controlled diabetes, it isn't because they aren't getting the right medication. It's because of this biopsychosocial factors and this education. we need to align our goals to get patients in the right frame of mind. So one of the diabetics I've seen in the last few months had terrible diabetes. HbA1c was 130 something. So that means his average blood sugar was probably about 20 to 30, if not higher, at home all of the time. That's average. Sometimes it was higher. Sometimes it was higher than that. And so I said, look, you've come to hospital. That's obviously not the place that you want to be. What if we look at it in 1 or 2 months' time? What would you like to actually be the case? And he was like, well, I would like the energy to do things like see my grandkids and walk my dogs. And I said, well, why don't we work together to achieve that? Essentially, right now, your blood sugars are too high. That means your body's saying, I want that sugar. I want to use that sugar so I can use it for energy. But you're not giving the medication that helps the body take in that blood sugar to use it. And so it's really important that we reverse that and we give you the opportunity to have that energy to do all those things that you want to do. And my hope is when I see him in clinic in a few months' time, he will have taken on board all of what I told him and used all of those other factors like playing with his grandkids and being able to walk his dogs as reasons to take control of his diabetes. This very complicated diagram is the ADA guidelines in terms of what medications we start next. That's the American Diabetes Association. There are NICE guidelines, but the NICE guidelines are unfortunately very out of date, and they suggest medications in an order which we don't use them. But what I'm going to do is, because you simply cannot go through this in any detail over a presentation, I'm going to break it down and we're going to think about the different sections. And so, if a patient's HbA1c remains above 53 millimoles, what we think about is what is the predominant thing that we're trying to achieve. We know that all of our medications are going to improve glycemic control. They're going to improve the blood sugars and thereby improve the microvascular complications. What we want to do is look at our patient and say, is Mr. Patel really high risk of cardiovascular disease, or has he had that? Is he at risk of heart failure or CKD, or is he developing that? Or is he very overweight? And that's what's going to make us choose which medication we go for. So as you can see, SGLT2 inhibitors are across the board very good, and that's why they're more and more commonly becoming the next drug we start after metformin. You've also got DPP-4 inhibitors. They have a slight benefit in cardiovascular risk factors, or GLP-1 analogs, which have a much better profile. But GLP-1 analogs, the real star is in weight loss. And so if you've got an overweight patient, you really want to consider a GLP. And then in heart failure or CKD, SGLT2 inhibitors are really helpful. And so you can find that often SGLT2 inhibitors tend to be your next line drug in the patients who will tolerate. Sulfonylureas do exist, and they are an alternative that you could consider. But with the weight gain and the fact that they don't really help with any of these outcomes, in fact, if anything, they cause weight gain, they aren't usually the most appropriate drug. Although if you had a patient who is very, very lean with diabetes, you might think a sulfonylurea may be a benefit there. Just an overview of a couple of so we'll think about the benefits, but we'll also think about the disadvantages of each drug. And so let's consider each drug once again. SGLT2 inhibitors, as you remember, they make you pee out your sugar. And so we need to think about the patient in front of us. Are they an elderly patient? Because ultimately they might get very dehydrated. Are they a patient who's had ketosis before, which means we're not going to give them that? Or are they at risk of UTIs, which means that, again, we're not going to think an SGLT2 inhibitor is beneficial. And they need to be aware of sick day rules. So if they're unwell, they must stop their medication. But we do have the benefits in cardiovascular disease, CKD, and weight loss. So often this is a very good drug to start. DPP-4 inhibitors Well, the benefits are that they do modestly, well, mildly and slightly increase, reduce your cardiovascular disease. They're weight neutral and they'll delay insulin. So if you want something that's a little less potent than an SGLT2 inhibitor and therefore has a little less side effects, you might consider something like a DPP4 inhibitor, particularly if they've got really bad renal function. You can't give an SGLT2 inhibitor if they've got severe CKD, but you can give linagliptin, for example. You might look at the patient in front of you and say, well, they're very overweight. And so let me think that maybe a GLP-1 analog might be the best thing, because actually what I want this patient to do in the next 6 months is lose a lot of weight. And so you might start a GLP-1 analog. Of course, it's got to be a patient who's willing to inject themselves. Although, as I said, oral formulations, so oral semaglutide, for example, is about to come in, opening the market of GLP-1 analogs being a little bit easier to take. But they've got great benefits in cardiovascular disease, but they do need to be aware of the GI side effects, which can be quite potent. And so you've got to have a patient who improves on it and is also willing to take it. And so what we'll do is at 6 months, we'll see, have they had weight loss? Have they had a reduction in the HbA1c? And if they have, then we will continue it. But if they haven't, then it's shown that the GLP-1 analog hasn't worked, and therefore we will discontinue it. Sulfonylureas, as I've alluded to, is not really our drug of choice typically, because of the increased risk of weight gain and significant risk of hypoglycemia, but we're definitely not going to consider giving it in the elderly, people at risk of falls or hypoglycemia, and particularly because of the very mild benefits in cardiovascular disease. However, it does very much work. It does reduce your HbA1c and it does improve your glycemic control. And so from a microvascular benefit perspective, it will improve things. And so it may be the drug of choice. And so we picked a drug, we picked a drug for Mr. Patel. We wait another 6 months and then we repeat the HbA1c to see, have we achieved what we're looking for? Well, either we have or his HbA1c will still be raised. Maybe a little bit better, but still too high, suggesting that the drug has worked, but it's not enough. And so we need to think of another medication. And again, we'll go through the same thing. What cardiovascular disease risk factors are there, heart failure, CKD, weight loss, and we'll pick a drug thinking about exactly the same side effects until we reach a situation where we have achieved exactly that. Mr. Patel is now on metformin, is on linagliptin, and on an SGLT2 inhibitor, and despite this, his HbA1c is raised. Typically, all of these medications will result in delaying the need of insulin to about 10 or so years. But at that point, for a lot of people, they simply do need to start insulin. We will consider starting a basal once per day, which will be our usual. But if the patient's got a really high HbA1c, if Mr. Patel's HbA1c is in the 90s, for example, we might think a pre-mixed BD or basal bolus might be more appropriate. So how are we going to start this? Well, again, 0.3 units per kilo. So for we might consider about 10 to 20 units, for example, Humulin I, which is insulin MPH, lasting about 16 hours, 16 units every morning, and that will work during the day. And then we'll have a look at his profile and see what's happening. We'll ask him to regularly measure his blood sugars, and we'll see. Is it high all of the time, suggesting that the basal needs to be increased? Is it high in the morning, suggesting that we need to give a longer acting basal? Is it that the blood sugars after meals are high, which means we might need to add in some kind of short acting component, either a mixed version with basal and bolus mixed in, or basal with extra shots of bolus with each meal. And we'll ask the diabetes team in the community or in hospital to help support with that. Because Mr. Patel is going to need some help in terms of injection technique, monitoring, titrating doses, management of hypoglycemia, informing the DVLA. You've got that 5 to drive rule and the sick day rules to make sure that he never stops his insulin because of the risk of developing really high blood sugars and not losing lots of fluid as a result. Perfect. And so that summarizes all the things that we want to talk about and consolidates it with a case. The things that we've learned are that the importance of identifying the type of insulin, type 1 diabetes versus type 2 diabetes, thinking about that weight loss, that short history, that young patient who presents with significant osmotic symptoms, who very much shows that they need insulin because they've got features of insulin deficiency, versus the type 2 diabetic who tends to be overweight, significant family history, long symptoms that have been affecting them for several months. We're thinking about the holistic management. It's not all about the medications. In fact, it's far from. Education, supporting, and considering all the other factors like smoking and alcohol, blood pressure control, and cholesterol, all of those things are very much important. And that biopsychosocial model to really work out, why is the patient not taking their medications? And then finally, it is the core part of this talk, which is choosing the right drug. Thinking about where the kidneys are, what organs are working, thinking about what diabetic complications have they got. Is it heart failure? Is it CKD? Is it cardiovascular disease, or are they particularly obese? And then thinking about the potential risks of each drug and using that information to work out which is the best for them. A shameless plug for my website, mindthebleep.com. You can scan this QR code and find it. And on our website, if you type in mindthebleep.com, the top article, because I've literally just published it in the last day or two, is on diabetes medications.